Hello, my name is Yejin Hong. I'm a medical student in the University of Calgary, and today we will discuss preeclampsia. The link between ophthalmology and OBGYN are important. During pregnancy, the woman's body undergoes many physiologic changes, and the eyes, as a sensitive target organ, are vulnerable in this state of change, especially in the cases for preeclampsia, where the blood pressure of the patient is elevated chronically, accompanied by proteinuria, this can damage the eyes as well. Preeclampsia is defined as hypertension accompanied by new-onset proteinuria during pregnancy, with one or more of each of adverse and severe complications. Proteinuria refers to protein found in urine and is defined as 0.3 grams per day or more in 24-hour urine protein collection and 30 milligrams per millimoles or more in the urine protein to creatinine ratio spot sample. Pathophysiology of preeclampsia is primarily due to the insufficient invasion by the trophoblasts into the myometrium. The result of this is narrower spiral arteries that supply blood to the uterus. This is very similar to a non-pregnant physiology, which is quite inadequate when the individual is pregnant. This leads to chronic placental ischemia, and to compensate for that and adequately supply blood to the uterus, the body increases the blood pressure. While this may satiate the uterus and the placenta, the blood pressure also increases for the rest of the body as well, which leads to some potential adverse effects. Some risk factors of preeclampsia includes nulliparity, new partner, advanced maternal age can increase the risk for preeclampsia, as well as family history of the disease, multiple gestation, and past instances of preeclampsia, obesity, and medical conditions such as chronic hypertension, renal disease, and diabetes mellitus can also make an individual vulnerable to preeclampsia. The adverse conditions that we have discussed in the previous slide will, upon detection, cause increased surveillance and treatment. So adverse conditions that apply to the mother includes the headaches and visual problems, chest pain and dyspnea, thrombocytopenia, increased creatinine levels, nausea and vomiting, as well as elevated ALT, and epigastric pain. For the fetus, the adverse conditions include abnormal fetal Doppler ultrasound on checkups, intrauterine growth restriction, and oligohydramnios, or insufficient amniotic fluid. Severe complications will warrant delivery and complication management as well. These complications in the mother includes eclampsia with a GCS of less than 13. This is a Glasgow Coma Scale, maximum of which is 15. Stroke or transient ischemic attacks, severe hypertension that's greater than 160/110, O2 saturation less than 90, and pulmonary edema. Thrombocytopenia less than 50 billion cells per liter. And acute kidney injury with creatinine greater than 150, INR greater than 2 with hepatic hematomas. These are the severe potential complications. For the fetus, placental abruption and stillbirth are a possible horrible outcomes of preeclampsia. So we have mentioned visual changes among the adverse effects. So what are the potential complications in the realm of ophthalmology in the instance of preeclampsia? Well, these include retinal vascular changes, that include the spasm of retinal arterioles, severe vasoconstriction in the eye as an end organ, leads to retinal edema and hemorrhages, as well as cotton wool spots from infarcts, blurred vision, photopsia and diplopia, scotoma, and visual field defects, as well as possible blindness are all the complications and are very possible for preeclampsia. These also, to note, is similar to the presentation of hypertensive retinopathy. Other complications of preeclampsia includes the development of eclampsia. This is preeclampsia coupled with generalized tonic-clonic convulsions. HELLP is another development that can occur, and this stands for hemolysis, elevated liver enzymes, and low platelets. Differential diagnosis for this disease includes gestational hypertension, chronic hypertension, Cushing syndrome, and chronic renal disease. Be thorough with the history with the patient, including questions like past pregnancies and method of delivery for each, asking for multiple gestations, preeclampsia history, whether in the patient or the family, and if there is an impediment to daily activities are all important questions. Ask about sudden change in weight, take blood pressures, and ask if the patient keeps a regular record of them. Do a complete ophthalmologic history, including any ocular surgeries, ocular disease in the patient or the family, and any symptoms related to the eyes that they're experiencing right now. Conduct a slit lamp exam with attention to the fundus and measure the visual acuity as well. Lab tests that can be done to investigate for preeclampsia includes the CBC with attention to platelets, measure the INR, and the PTT. Liver function tests and creatinine are also important. Urinalysis for proteinuria and the urine protein to creatinine ratio as well. Treatment of preeclampsia includes first the educations about which signs and symptoms they need to be aware of and for what they need to return to the hospital. Increase the surveillance, and we could also give medications. For mild to moderate, we can choose labetalol per oral, nifedipine extra length per oral, or methyl-dopa per oral. This is either for blood pressure greater than systolic 130 to 155 over diastolic 80 to 105 without other conditions, or for systolic greater than 130 over 139 over diastolic 80 to 89 with other conditions. For severe preeclampsia and hypertension, we could use labetalol IV this time and nifedipine short-acting per oral to acutely control and with precision, and hydralazine as well. This is for blood pressures greater than 160 over 110. For advanced gestational age or severe complications, immediate delivery should be sought for. 4 grams plus 1 gram per hour of magnesium sulfate is a prophylaxis for eclampsia. This compound has a neuroprotective effect. ASA can be preventative also for high risk of future preeclampsia. So hopefully we were able to show you that preeclampsia demonstrates a link between ophthalmology and OBGYN. And here is a summary slide of everything we have talked about with regards to preeclampsia. Here is a reference for the information that we have provided in this slideshow. Thank you for watching this video.